All right, welcome everyone. This is Dana Selver for those of you on the web, and welcome to our first nurse staffing open house. We are looking forward to doing these. We're looking forward to getting a lot of feedback, mostly probably online through the web, because it is a bit of a pain to drive here to the Lloyd District, but we do appreciate those who have come in person, and we really appreciate your participation. Participation really makes us a lot stronger, and it gives us a lot of context and that we can take out and make sense of applying the actual nurse staffing law. So there will be 3 of these, and we'll talk a little bit more about those. I am the section manager for healthcare regulation and quality improvement. And Annabelle, go ahead and introduce yourself.
Hi, thanks for coming. My name's Annabelle Henry, and I'm the program manager for the program that's implementing these rules and statutes. Health facility licensing and certification. You'll know us most commonly by HFLIC.
All right, thanks so much. So everyone has the agenda, I think, online and here in the room. We're basically going to do what I call the flyover, the overview. Some of you have heard that before, so thank you for bearing with us, and some of you haven't, so it might be new. And these PowerPoint slides will be available, and I do encourage you to share them at your hospital level, just to kind of give your team an overview about what's changed if you haven't already done so. And feel free to steal shamelessly, because we want you to practice and use all this information. So we'll go ahead and get started. I'll do a couple of an orientation about Senate Bill 469, about some of the high-level changes, and then Annabelle's going to talk more about the program and the survey process, which is probably most interesting to most of you. So, and then finally we'll take some questions at the end. The question process for the webinar, is that is organized? Yes. Hopefully. Okay, so that should be obvious. If it's not, I will let somebody else step up to the microphone and tell you all about that. But for those of you here in the room, we do have question cards in the back, and we do have some comment forms for the rules. If you want to fill out anything about the rules, you can fill it out now. You can send us an email, and we'll tell you a little bit more about how to do that. So so we'll go ahead and get started. So in 2015, Senate Bill 469 passed. There are some really high-level elements. We've had a nurse staffing law since 2001. It was changed in 2005, and then finally in 2015 they made some substantial changes to the law. This is hospital nurse staffing only, just for those of you who are interested. Some people ask, is this for ambulatory surgery centers too? No, people, this is for hospitals only. It is, parts of it are in effect as the law passed, other parts are at other dates, and you'll see some of those dates in here. So we'll go over the main elements. Hospital nurse staffing committees have changed. They have had a hospital nurse staffing committee since 2005, but the hospitals were required to revise their hospital nurse staffing committees according to the law and have that in place by January 1, 2016. So the changes are that there is a different kind of equal representation, and there is one added position for a non-RN. So all specialties and units are represented as they were before. There's a new element of union involvement in selecting those individuals who serve on the hospital nurse staffing committee. There are co-chairs, a nurse manager and a direct care nurse, and they have certain responsibilities and privileges a little bit different than it was before. They are to meet quarterly or at the call of either of the co-chairs. The minutes and the motions and the vote outcomes need to be available. The members are released from assignment to attend the committee meeting, so that's to enable all members wherever they are working to attend the meetings and participate. And staff can report patterns of of requiring overtime for non-emergency care. Basically, if they see a delay, they can report that to the nurse staffing committee. I think overall the changes in the nurse staffing committee are about transparency and about balance, and so I think that you'll see that when you look at some of the language in the statute and in the rules then. Hospital nurse staffing plans, they are required to be implemented. I imagine that many of you are working hard to get that implemented by January 1, 2017, and we are working hard to get rules in place and to get more of these outreach sessions to you and answer your questions. The hospitals have to implement the staffing plan as developed by the Hospital Nurse Staffing Committee. That's pretty concrete. That is new, and there are exceptions for certain emergencies, and that will be in the rules. The staffing plan has to consider, probably similar to the way it used to, but competencies necessary to meet the patient needs, meals and rest breaks, rates of admission, and then total diagnoses. And there is a little bit of a change, I think, from before about some of the tools used for the nurse staffing plan and what it needed to consider. So you can see that in the rules. Staffing plan can't rely solely on the external benchmarking measures. There's a new impasse mediation. There was always an impasse mediation in place, but this one has a requirement for the Oregon Health Authority upon request, if the hospital nurse staffing committee comes to an impasse, that we provide a professional mediator for that situation. And so we're working out and getting some detail out there for folks to know when is the impasse. So, and when can we do that, and how does that process work? So hospital nurse staffing committee has to review the staffing plan at least annually, and they have to consider this list of things, and I won't read that in detail, but similar to previously, but it takes into consideration some of the new provisions in the new nurse staffing law. So a couple of things that are in effect right now, although some of the rules are being drafted. The hospital may not require nursing staff to work under certain circumstances, and you can see those here, beyond the agreed upon shift. And then there are time limitations, 12 and 24 hours, and there needs to be a rest break. And so that is a new provision, or at least it's revised. Hospitals may require an additional hour of work under certain circumstances, and that will be in the rules. If the staff member agrees to overtime, they're accountable, and I think that actually is an old provision or something similar to before. They're responsible for notifying their supervisor if they can't do that. Hospitals must post nurse staffing information and complaint contacts, and they need to maintain records. And that's really part of the transparency information, I think. Hopefully, it was designed, and at least from our perspective, we will have the reports online. We're trying to have as much information online as possible so that any questions can be answered quickly. The hospitals are actually also required to have those minutes available, have the outcomes, have the decisions, so that all nurses that work at the hospitals can, and all nurse managers, everyone knows what happened at the nurse staffing meeting, and so that it's not it's not difficult to access. So there's really the transparency effort there. If we go to the next slide, sorry, it's behind me so I can't see. And this one actually is kind of interesting because you'll see the agency responsibilities, and the agency is the Oregon Health Authority in this case. And we've kind of grouped it into new and existing might have changed a little bit, but for the most part, existing responsibilities, that means that comes from, used to be in the 2005 law and in our existing rules. So the audits, that has changed. Previously we did a certain percentage of the hospitals per year. It was required to be a random selection. And now we will be doing a third of the hospitals each year. So that means we'll be doing a full nurse staffing audit or survey annually, or every third year at the hospitals. We are required to interview the co-chairs during the audit. We are required to review particular records, and this is actually an existing one, and conduct certain interviews to determine compliance. But most surveys or audits in our circumstance, they do include observation and interview, and then document review. So that's pretty typical. Providing a written report of the audit findings to the co-chairs, that's new. Generally, our survey reports go to the CEO and are distributed through however the hospital is organized. But now there will be an explicit report sent to each one of the co-chairs. Conducting the second survey and to determine compliance, that's new. Before, the revisits were optional, and there's still an opportunity to go out and do that revisit, but there is a requirement on our behalf to do that again. The complaint investigation, so an audit is a routine survey that just looks at everything and it has no particular focus. A complaint investigation is a response to an allegation of noncompliance that we receive here at the health authority. And in that, you can see the top elements, the interviewing the witnesses or the interested parties, and taking evidence. That is as an existing requirement. There is a requirement to compel the production of certain documents to determine compliance with the nurse staffing law. So that list you can find in the statute and rules. And providing the written report of the complaint findings to the co-chairs again, so that's the same as the other. And then conducting the revisit to ensure that compliance, that we can confirm compliance on site. So posting, there's your transparency issue again, posting the audit investigation reports, plans of correction, any civil penalties, hospital license revocation, suspension notice. So all of that will be posted on our website. It is currently available by public record, but now it'll be easier to get to. So that should answer those questions and cost us a lot less in public records requests. So amend and adopt the administrative rules. We've already had that in place. Staff support for the Nurse Staffing Advisory Board, that is actually new. We have 3 new positions, which is really exciting for us. We can really put some muscle toward meeting these 22 surveys per year and maintaining staffing for the Nurse Staffing Advisory Board, so that's pretty exciting. In addition to doing all the posting, which is a big lift for us, because you can't just post anything at the state. You have to read it several times, and it has to go through approval processes and things like that. So kind of like probably at most hospitals. And mediation services and possible civil penalties, same type of thing. All right, more implementation, increased staffing. Oh, there you go. There are the new positions, the policy analyst. Many of you know Anna Davis, and she's sitting here, and I don't think we can pan to her, but her contact information is on the back. You can contact her anytime. If you have questions, if you have issues, she can always triage your information to anyone who needs to. And some of you are smiling here in the room because I think you've already talked to Anna. So we're really lucky to have her and have that position. A client care surveyor dedicated solely. Our hospital team right now, we used to have 2 exclusively for hospitals, and now we'll have upwards of 5. Now that is a combination, and they will be doing other surveys, but it is a big difference for us. So we'll have much more ability to do our federal work and our state nurse staffing work. So that's very exciting. And then administrative support, that's Lisa Finkel, and her information is not on here, contact information. I'm looking at, I don't think it is. Anyway, Anna knows her information. She may refer her to you, but she will be the one when we're looking at all the posting and getting that information if you have questions, quick ones. So she's an extra resource that we're also very excited to have. Additional open houses are on August 25th, and at that open house, if you don't already know or haven't seen, we'll be going through the rules in detail and answering questions to that. And then in the December one, we're going to be looking at the tools that those surveyors use to go out and determine compliance. And so the tools, they sound sort of fancy, but they really are sort of the requirements put into a checklist. But sometimes I think hospitals find that helpful to know how the survey process works. It feels a little more comforting. You can go through it and do your own mock survey if you want to. You can have that conversation, share those tools at the nurse staffing committee meetings, and that's really what we're kind of getting people ready for 2017 and the 22 surveys a year. So and answering all your questions about the survey process and what types of things are going to be acceptable for documentation for this, that, and the other thing, which is going to be substantial. Rulemaking is in process. The rules will take effect on July 1st. We have our rules hearing tomorrow, May 18th, from 2 to 5 p.m. It's here at the Portland State Office Building. If you are unable to attend in person, we're happy to take your comments in written form. We can take them anytime, today, tomorrow, up until May 23rd at 5 p.m. when the window closes. So those comments can come in written form. They can come in an email. You see there how to submit them. Email publichealthrules@state.or.us. But if they come into one of us, we can, if you accidentally send it to Annabelle or to me, or you happen to know one of us or to someone else, we generally reroute it, and that it'll be time stamped, as far as the email goes when we received it. So we'll definitely give you some feedback that we're forwarding that if you don't end up sending it directly to Tracy Candela, our interim administrative rules coordinator. So written comments available, and again, sheets in the back if you want to just write something by hand, also absolutely an option. So we expect some testimony in person tomorrow, but we expect a lot of written comments. So that's super, and either one is perfectly acceptable. So the Nurse Staffing Advisory Board, and I will just whoosh through this because I know we need to get on to the next little part. So the Nurse Staffing Advisory Board is new and exciting, and it gives us some opportunity to get feedback from across the state on how to think about some of the really specific nurse staffing issues that right now have been kind of worked out at the Nurse Staffing Collaborative that the ONA and the Hospital Association have run for a while. But this is going to be a little bit more concrete about looking at trends and being able to have access to those reports and to the data and to slice and dice it depending on what people are seeing and what kind of speculation or hypothesis we think this is happening, or they get feedback from the hospitals, and we'd really like to understand how hospitals are complying with this, or how they're not, or how they're, what issues there are. And so we'll be able to answer those questions, and we'll get feedback from the Nurse Staffing Advisory Board. If there are any rules changes necessary, they'll give us feedback on that too. We'll be looking at how that first year of surveys is really going to give us quite a bit of information, I think. And the first cycle after 3 years, when everyone has gone through it, it'll be particularly interesting to see how the hospitals are faring and how what kind of issues are coming up. And maybe we look at some of the rule changes or some statutory changes, and the Nurse Staffing Advisory Board will be a vehicle to give us feedback on that. Their duties are spelled out here. They're very explicit, but they go beyond that. They advise the OHA on administering the nurse staffing law, as I mentioned. They identify trends, so they look at the data on the reports. They review the enforcement powers and processes, and that is, how we end up interpreting the plans of correction and things like that. So they give us feedback on that. They ask questions. We try to answer, and then we listen to the interpretation and maybe some solutions-oriented recommendations, hopefully from the Nurse Staffing Advisory Board. And finally, annually in September, yes, they have a report due to the legislature. That's a pretty open-ended thing, and we're actually going to be talking about that at this month's meeting, so that should be interesting. I think looking forward to a nice foundational report, and that is taken to the legislative days annually in September. The meeting dates you can see there. These are public meetings. If you don't have time to come, I think you can call and listen in Yes, yeah, so that'll be, yeah, and we do have that, so you can call and listen in. You can ask questions and offer comments in the public comment period. And you can also get all of the written information online. There is a wonderful transparency website, and if there are other advisory committees you want to attend, you can go to the Oregon Transparency website, kind of like tripcheck.com, but it's for rules committees. I think it's really terrific because it really collects everything in one place, and I think Anna likes it too. Yes, I know. So it's a terrific source, and if you ever forget any of that, you have our contact information. You can just say, hey, I really want to understand, I want the minutes, or could you please share this, that, and the other thing with me, or answer a question. So we're here for you all. You can see the, I'm going on slide 10 now, I think. The Nurse Staffing Advisory Board is composed of an equal number of managers and direct care nurses, with one of the direct care being optional non-RN. We are awaiting appointment. We, every some matter of days, actually we're skipping from weeks to days, we do remind the governor that they need to give us that last appointment. So we're working towards that. Right now we have 11 members. We have 2 co-chairs, Susan King and Carol Bradley, and they serve a 3-year term. And basically those, the governor's office really tries to balance the membership and try and get people and members from out of the Portland metro area, out of the I-5 area. We do not appoint, so if you do have complaints about the appointments, you do need to contact us, and we will pass that on. So, but the balance is really an attempt to get small, large, and medium hospitals, and get some hospitals with unions, without unions, so that we can get sort of that balanced feedback and understand how the hospitals are meeting the nurse staffing challenges of the 21st century. And I will pass it off with you for that.
Well, let me just echo Dana's sentiments. Thank you for everyone who took the time and the trouble to come in person today, and for everyone who's logged on right now or chooses to watch this later. We really appreciate your presence and your input. Again, my name's Annabelle, and I'm the program manager. And my role today is to tell you a little bit about our agency and our program in particular. Sometimes it's helpful to understand the group that's guiding us through the rules and the enforcement of those particular standards. And I'll also tell you today a little bit about the survey process. Many of the individuals we speak with haven't been through a survey personally and would like to know more about what's coming. So again, slides are behind me. Apologies in advance if I'm off cue a little bit, but we'll do our best. Right now, you should have a summary screen of the section that our program is a part of. The Oregon Health Authority is a large agency. Due to our size, we've been subdivided into different divisions, and our program is located in the Public Health Division. That's the building that you're in today, Portland State Office Building, and so you'll know us at this location in Portland. Our division, however, is also quite large. We have about 730 positions, so we've further been subdivided into centers. And our program is located within the Center for Health Protection. Much like it sounds, that's essentially the regulatory arm of the Public Health Division. We have approximately 230 odd positions. Because we're a state agency, at any point in time, we're a little bit above or a little bit below that number. So again, due to our size, we've been subdivided into sections. Our section is the Healthcare Regulation and Quality Improvement section, HRQI for short. You've probably seen it before in statutes and on websites. HRQI does 4 primary things, and you'll see those items behind me on the slide. We regulate healthcare facility construction projects through our Facilities Planning and Safety team. We manage the Oregon Trauma and EMS programs. We manage the Certificate of Need program. And we also regulate non-long-term care facilities in acute care and community-based settings. And this is a large collection of provider types, as you can see behind me. It's anywhere from 16 to 17 different types of providers, depending upon how you count. For the most part, when we refer to providers in our program, we're talking about facilities, but you will see on that screen that we do also license or certify hemodialysis technicians, and that some of these facilities are large and some of them are small. Some of them are state-only licensing programs, like in-home care agencies. Some of them are only federally certified to participate in the Centers for Medicaid and Medicare's Medicare program, for example, rural health clinics, and some might elect to be both licensed and certified. Let's advance one slide onto 13. This is a little bit tricky because there's some animation here, so just bear with me. I'm going to walk you through an org chart for our section with a little bit of a focus on our program so you can understand the size and scope of what it is we do. Of course, you won't be able to read these names. It's a little bit small at this point, but what you'll see is that some animation pops up that colors certain boxes. So the first 3 boxes that pop up give you a sense of our management structure. The first position is our center administrator, and that position has been filled with an interim appointee for a little while, and we now have a permanent appointee to that position. His name is Jerry High. He's been with the agency for quite some time, and we're thrilled to have someone in the position who understands what it is we do. The next box you'll see is Dana's section manager position, and the box after that you'll see is my position. And the next animation will give you a red square. That highlights the Health Facility Licensing and Certification Program, which is again the program responsible for construction document review of healthcare facilities, as well as survey and certification activities that cover both state-only licensing statutes, federal conditions of participation, and nurse staffing statutes. So what you'll see is that we have a team of 4 plans examiners that will pop up in blue, supported by 1 administrator and a collection of contractors covering our construction document review workload, and then a collection of 15 surveyors. Now, for the most part, these are registered nurses. 14 of the 15 are registered nurses. We choose to hire clinicians and then teach them how to become surveyors, and 1 member is an allied staff member. That survey team is supported by 3 support staff members dedicated to survey and certification activities. And up on the top in red is Anna's position, that policy analyst position that we're so happy to have assigned to us for the first time this year. So it is a large team, and if we advance to slide, well, at this point I think we're on slide 14, you'll see a written detail of those team members. What I would point out at this point is that our program workload is really broken up into 2 different types of work. The first is a fixed or standard workload that's easy to predict. We know, for example, which types of surveys we need to complete each year to meet federal, state performance standards, as well as state relicensure standards. And we know, for example, in a general sense, how many construction document plans we're expected to review each year. You'll also see, however, that a lot of that workload is variable, and this really captures our complaint workload. EMTALAs are an example of short-term, high-priority federal complaints that we investigate on a timely basis, immediate jeopardy situations, and then standard federal and state complaint investigations are also part of this variable workload. Let's go forward one more. So let's talk a little bit about the survey process itself. Again, many of the individuals we speak with haven't personally been through a survey process, and it's helpful to understand what a normal survey or a standard survey looks like. As Dana mentioned earlier, with respect to nurse staffing surveys, we've increased under this new regulatory framework the number of surveys that we expect to do every year. In the past, under the old framework, we did approximately 5 each year, and now under the new framework, we'll do 22 every year. So we've jumped from a once every 13 years to a once every 3-year survey cycle. The first thing that happens when we conduct a survey is preparation, and that we've described as our pre-survey preparation stage. It involves a review of hospital licensing and compliance records, as well as the development of an informal survey plan. And those are activities that our surveyors complete on-site as a way of preparing before they enter the facility. We'll look at waivers, if any have been issued to the facility itself. We'll look at the services they provide. We'll look at their licensure status, their ownership status, records of prior complaint investigations, records of prior survey reports, and we'll also take a look at their roster of on-campus and off-campus service locations. We know the off-campus service locations as satellites, so we'll take a look at the number and types that are available to this particular facility. Going forward from there, we're on site, and a standard survey can last anywhere from a day to 5 days, depending upon the scope of the survey itself, the size of the facility, and its distance from our office. On day one, however, the same thing occurs. We conduct an entrance conference with hospital administration, and those activities involve a face-to-face meeting, a description of the purpose and the scope of the survey. If, for example, we're completing a complaint investigation, we'll have a narrower focus than if we were to be completing a recertification or a relicensure survey, or in this particular case, a full nurse staffing survey, which is what we're going to focus our discussion on here today. What we like to do during that entrance conference is also explain a little bit about the survey process itself. We present attendees at that meeting with something called a needs list. It's designed to outline what it is that we're going to be asking for to the best of our knowledge, and the types of resources that we expect to require. For example, a dedicated room for staff to collect materials and review documents and the like. You'll also see that there are some variabilities in terms of the things that we'll leave with. Days 2 and on really have to do with how we gather our information. What we'll do is make observations while we're on site, and that might be observations on campus, and it might also include observations when we're off campus. We'll, of course, conduct interviews with staff. Those interviews might also include interviews with patients, family members. Under this new nurse staffing regulatory framework, we'll be interviewing both co-chairs of the hospital nurse staffing committee. We'll do document review of policies and procedures that relate to the rules that we're enforcing, contracts, personnel records, patient records. It's a variety of things that we look at both in person and on paper that are designed to assess compliance with this particular set of rules. The result of this review of documentation and conversation and observation is that the surveyors are able to collect or develop preliminary findings at the end of their site visit. And the last day is almost always concluded with an exit conference. And during this exit conference, again with hospital leadership, the survey team's purpose is really designed to communicate those preliminary findings, to give the provider a sense of what it looked like we found and where we think we're going to be going when we draft our formal survey report. While the findings are preliminary, they're quite insightful and provide the provider with a first glance or a first opportunity at what, if any, changes need to be made going forward. Let's advance to slide 17. At this point, I'm going to shift a little bit towards where we hope to go as reflected in our draft rules. As many of you know, we're in rulemaking, and draft rules are available for your review, and we're looking for comments. One of the things that we've tried to do in our draft rules is make more transparent our survey processes and also performance standards as a way of managing expectations and communicating more clearly performance standards that we expect to hold ourselves to, and also performance standards that the provider would be held to. So this slide is just a quick summary of some of those measures that you'll find in our rules. For example, what you'll see is some timelines set forward in our rules that detail how quickly reports will go out or how quickly plans of corrections will go out. So what you'll see is that within 30 business days after a survey closes, that's after that investigatory portion of the survey closes, you're going to receive, if you're a provider, a statement of deficiencies. And these documents will be issued both to the hospital administrator on file, as well as both co-chairs of the hospital nurse staffing committee, as a way again of improving transparency. These documents referenced here today previously as a survey report and in rule as a statement of deficiencies are the written report that reflects the findings of the survey team while they were on site. And the intent of this report is very in much detail to link each particular finding to a supporting rule. What you'll also see is that within 30 days, we ask licensees or providers in this case to submit a plan of correction. And that essentially is a written document drafted and submitted by the provider, the hospital in this case, that addresses point by point any deficiencies identified by the surveyors while they're on site. It's a way of prompting that conversation within the facility of how to return to compliance. So you'll see that those performance standards match, and we're looking for a cycle that is timely but not too oppressive. You'll also see under this new regulatory framework that revisits or re-inspections are part of this new model, and that within 60 days after a plan of correction is approved by the state, there will be a follow-up visit or a follow-up investigation to confirm that the proposed solutions submitted by the provider have been implemented and have allowed the provider to return to compliance. Let's go forward one more. So at this point, behind me you should see contact information for everyone. I'll draw your attention to two particular email addresses right off the bat. The first is Anna's up top, and that's Anna L. Davis at state.or.us, and the second is our general mailbox. Anna is our primary point of contact for nurse staffing questions, but again, I think as Dana mentioned earlier, you are also welcome to use our general mailbox or to reach out to either me or Dana if you have more specific questions. We follow a pretty tight communications network inside, so we'll definitely be looking at those questions and responding as soon as we can. And I think we're going to go to questions now, right?
I think so.
All right. So there are a couple ways. Do you want to walk us through this? Or
No, go ahead. No, go ahead. And
this is the first open house we've done, so we were really trying to prompt a conversation at this point and just solicit as much input as possible. So there are really lots of ways to get us questions and comments. There are some note cards, I think, that have made their way around the room in the back. You're welcome to submit questions today or just to participate right now in a question and answer session. As Dana mentioned earlier, our intent for these open houses is to become more and more focused towards implementation as the calendar year moves forward. So rules should be promulgated and in effect by July 1st, so that's when our rules will be up and running, which means that August open house will really focus on the specifics of our rules, or at least that's our hope. And our survey tools should be finalized later this year, which means that in December we'll be going over our survey tools in detail with attendees. But there's really nothing off limits today, so I'm not sure if we have a microphone that we can circulate, or we have a small room right now. I think we'll pass a microphone to ensure that the webinar can capture those sounds. But if anyone has a question right now, you're more than welcome. We have time, we have the room for a while.
right, and since it's a small group, I think we can just raise our hand. And I am hearing from the stage right that, as I point left, right, I'm hearing from stage right that we are to repeat your question. So we can hear you, but just so we can repeat it, and you can nod and say, yes, that's what I asked. And then, and so that those on the webinar can hear us. So if they can't hear you in the room. I don't know for Britt, and we are practicing with Britt. This is our first session, so we'll try and get this right next time. Anyway, any questions?
And if you're shy, you can just sneak in a note card later. That's
Or everyone
okay too.
wants to throw themselves into the 5:30 traffic? No, maybe not. Yes. If you could maybe just give us your name and hospital if you are so inclined. So.
My name is Ron Nymark. I'm with the Oregon Federation of Nurses and Health Professionals.
Uh-huh.
And so my question is in reference to the mandatory overtime rules.
Mm-hmm.
And so under those rules, once an employee works 12 hours in a 24-hour period, what is the requirement? If they're on standby after that point, can they still be required to come into work? So you've got people that take standby, they work a regular shift, they're on standby overnight, they're usually called in to work. Is that now not allowed?
Okay.
So the question, as I understood it,
Yeah.
was does the statute addressing mandatory overtime, which we know to be fairly similar to what it used to be, prohibit on-call hours with those caps? And again, the rules are in draft form right now, but we've received many questions that address a lot of specific hypotheticals. So what we're developing is an FAQs that will walk readers through the top 5, the top 6 possible combinations of mandatory overtime hypotheticals that we'll be releasing after our rules are in place. Really has to do with how the word required is interpreted, because of course how that word required is interpreted drives whether on-call is captured or not. What is clear right now is that voluntary commitments to additional shifts are permitted. So you'll see that information coming out from us, and you are welcome to ask additional questions if it's not clear. We are really working hard to make sure that those possible hypotheticals, lots of different questions about how that particular rule is going to play out, are addressed. Yeah.
The staffing committee, is the entire staffing committee, the labor side, need to be released from work so that they can attend the staffing committee? Or is there only the number that management sees fit, or the number to make it an equal number for voting, or does the entire staffing committee need to be released from duty?
So the question for those of you on the webinar out in the interweb, so the question was, does the staffing committee need to be released from work, and does everyone on the staffing committee need to be released? Is there a new rule about that, or is it? And the alternative was.
Or do they just need to release enough people to make a quorum to be able to vote?
Right, a quorum to be able to. Okay, so or do they just release? And this is the hospital administration, making them available to go to these meetings. That's a really interesting question, and I don't imagine, and it would have to do with the interpretation of committee members, as far as I'm concerned. If they are formal members of the hospital nurse staffing committee, they're all created equal. And I don't see any reason, and this is from my perspective sitting here right now. Now, this is a hypothetical, so I can't, there are maybe cases where the answer won't necessarily firm, but the committee members are created equal, and I think that requirement to release would apply to all members. So, and I'm not really sure why it would not at this point. So, and Annabelle is madly looking at the language. I mean, that's a question that we'd have to look at the situation and then look at the language.
Yeah, and I'm sorry, I didn't catch your name.
Oh, I'm sorry, I'm Jenny House. I'm from the Oregon Federation of Nurses and Professionals and Transformative.
Thank you.
Okay, thanks.
My memory of the statute is the same, and what Dana's speaking to is really some of the conversations we've had during the rulemaking advisory committee meetings. There has been some variation across the state in terms of how nursing units are defined, and that of course drives membership. What our current rules speak to is that it is still within the provider's discretion to define those nursing units, but then once those nursing units are defined, equal representation is required. So what Dana's speaking to is once the representation has been fixed, all staffing committee members are equally entitled to attend those particular meetings. Yeah, and hearing that there's still some confusion, or I'm inferring that there still might be some confusion out there about that, we can add that to some of our FAQs just to clarify for everyone going forward.
Let me just add one more thing before we answer the next question. The issue with representation of all units and areas of the hospital, that is different for a small, medium, and large hospital. One, because I think smaller hospitals have less nurse managers and more direct care nurses often, and the reverse. Well, I guess the same would be true for a large hospital, but a large hospital might have 6 surgery units, right? Or a pediatric, and so the hospitals do have the discretion to decide how to bundle and get representation. However, once you're official, you're a member of the nurse staffing committee, then you're on, and they're created equal, so. Yes, question?
So, Phil Davis from HR and Karen Burnett, you just answered it.
Oh, the bundling
Yes,
for a large
you're talking
hospital?
about the provider discretion that you were talking about. Because actually, when you read it, SB 469 does kind of define units, arenas, and it didn't really say what you just said.
Okay, so, and I didn't get your first name, but I'm going to say a representative from Kaiser Permanente was asking a question about how hospitals have discretion to define how those units are put together and how that representation is put together. There is some language in the rules that you can take a look at it, and since the rules aren't done yet, we won't be able to definitively answer that. But that will be a question that will come up. It will be an issue that the hospital surveyors will be looking at about how the representation is organized and how. And making sure that they're all represented, all of the units and the service types, and so we'll have a little bit more information in the FAQs and after the rules are promulgated, if that's helpful. So, yeah, question.
Jen Baker from the Nurses Association. Could you walk us through, I know there's not complete discretion for a hospital to define what is a unit. Could you walk us through what's in the proposed rules for how a hospital can go about coupling units together?
So the question was whether we could provide any additional detail as to how nursing units are defined or proposed to be defined in rule. And at this point, because we're soliciting comments on that particular issue, particularly, I would defer until after public comments close. We have had quite a bit of discussion, both in Rule Advisory Committee meetings and comments to date, and have, if you've been tracking those conversations, have oscillated back and forth between a fixed definition in draft rules for nursing units and then back to the current standard, which is the provider-defined option for nursing units.
Could you share with us what's in those proposed rules that are available online and that you're getting comments back on?
You mean where they are? They're on the Transparency website.
No, she I think she wants the detail of the.
Oh, you're
of the
looking for a
rule.
reading?
Yeah.
Sure. Unless you want to.
No,
Okay.
Seek.
Yeah, that's not
No,
my
that's-
natural. Anna, do you know a quick reference to this one?
So I think you're in 105 on page.
105, that was it.
Page 11 of 16, about a quarter of the way down, little b.
And we're now looking at the organ administrative rules for those of you who either A, have them on your lap, or B, have them on your computer screen or on your second computer screen if you're watching the webinar on the other one. 333-510-0105, and we refer down to section, what is it?
4b.
4B, as in Bravo.
So just to clarify the question as I'm hearing it, when some of these rules are enforced, one of the first questions the survey team has to address is what is the definition of a nursing unit, because that of course drives committee membership and it of course drives then some of the audit protocols that we follow. And so as I understood the question, you're looking for the current state of the draft language that addresses how nursing units are defined. And what we've done during the course of rulemaking is we've entertained some fixed definitions for nursing units, and then for a variety of reasons that are outlined in those committee meeting minutes, moved away from that fixed definition because there were too many adverse consequences to a fixed definition, and returned to the current standard, which is allowing the provider to define what a nursing unit is. Within reason and, of course, within the bounds of the current statutory framework, which is fairly well defined. So the request was for a targeted location in the draft rules for those of you watching via webinar or attending today. And as Dana mentioned, we're in 333-510-0105 Section 4, subsection B, and I'll try to read slowly here, but the language is, in draft form again, that the staffing committee shall include at least one direct care registered nurse from each hospital nurse specialty or unit as the specialty or unit is defined by the hospital. And that's very close again to current language and current practices. Is that helpful, Andy?
Could you repeat that?
Yes, absolutely.
Sorry.
Not at all. I didn't start it the first time. Let's see if I can make it a second time. The staffing committee shall include at least one direct care registered nurse from each hospital nurse specialty or unit as the specialty or unit is defined by the hospital.
Can you give us the citation again?
Absolutely. It's 333-510-0105, Section 4, subsection B, and that will be a lowercase b under our administrative rules protocols. Yes.
And just a clarification, Misty Richards from Kaiser said as well. So this will be a different delineation than what they already have. For example, my employer has a unit called One South and a unit called One North. This will be a different delineation than what's already set up.
No. So the question was, does this language change the current standard? And the answer is no. This language is actually a reflection of the current standard. The current standards allow providers to define hospital nurse specialties or units. And what we see is that that conversation is then, of course, part of those nurse staffing committee meetings.
So define them for purpose of the staffing committee, or define, that's my question, is that they're already defined for other purposes in the businesses, in the organizational business, they can be defined differently for the staffing committee.
So the question is, on the survey side, do we see variances between how nursing units are defined that would affect membership to the hospital nurse staffing committees in a different way? Am I tracking that question
Yes.
correctly? Okay. I can give you just my brief experience over the past couple years with the program, but I haven't seen variances. Definitions are usually outlined in the charter and then carried forward from there.
Okay, so the charter is what?
That's our
sets the
go-to
precedent.
document to begin with, yes.
Excellent, thank you.
Absolutely.
And there's no reason why some hospitals might reconsider how they're doing things as they're updating their nurse staffing committee and updating their nurse staffing plan, that they make some changes for one reason or another. So that may be the case, but there's the hospital operations are one thing, and the nurse staffing committee is another. And so if that helps at all.
Thank you.
Yeah. Yes.
Carrie Dunn, Kaiser Westside. I listened to the webinar that was about the updates that we're having, and they had mentioned that the non-registered nurse position would be like a CNA or something like that, but not a tech, and there was other things that they were not including. Is that still, you look confused?
Okay, so the question was Kaiser Westside, not Kaiser Eastside, so there you go. It's a very robust Kaiser representation here this evening. That was an editorial comment, but not a judgment by any means. We're happy to have anyone here, so we're not alone staring at a funny blank thing. Camera, yeah, that's good. So the question was, listen to the webinar a couple of weeks ago and about the nurse staffing committee membership being a certified nursing assistant, not a non-RN, so to speak.
The one non-RN.
The one
It sounded
non-RN.
like it had, the one non-RN still had different little rules, like it couldn't be a tech, or tech, it had to be a CNA.
Nursing staff, yeah, and nursing staff is defined.
Okay, so that's what.
Practically, at least for us, because we like that. So nursing staff is defined as, and I don't have it here, someone would have to point me to it, but it is a certified nurse's assistant, an LPN,
And a registered nurse.
and a registered nurse, that's it. And so it does need to be nursing staff. Although there is, and I don't know if this is in the rule or the statute or if this is just in my practical application of the nurse staffing law, that it is clear to everyone, both us and you, that there are a lot of other individuals that work with nurses as techs or techs, ED techs, fill in the blank techs, that have a lot to do with nursing, but they are not nursing staff proper as defined in the statute. And so they play a role, and in the nurse staffing plan, you might want to take them into consideration. But there are certain areas where it is really specific about nursing staff. So, and that's going to be up to the hospital depending on how tech rich they are or not, or other staff. So, trying to think. There's one person I think from Kaiser that hasn't asked a question yet. So I think she should feel quite compelled.
No pressure.
Yeah, no pressure. So.
She's attacked.
No, really?
Shut down.
Oh dear.
I still love you.
Yeah.
Are there any defined rules around caucus, ability to caucus, labor being paid? It says that we should be paid for all time that they work on the committee. If they're doing work prepping for the meeting, is that considered paid time or not? Have the rules gone that far in expanding on? Or is there only set meeting time and that meeting time, and who defines that or chooses that amount of time?
So the question was how, with what specificity do the rules or the supporting statutes define the mandatory paid leave for members, direct care members of the hospital-wide nurse staffing committee that want or are able or required to attend that committee meeting? And what we've done in the draft rules is mirror what was in statute at this point. And you can see the current language is in the same rule that we just discussed. It's in 333-510-0105, section 3 in this particular case. And it states the hospital shall release a member of the staffing committee from his or her assignment to attend committee meetings and provide paid time for this purpose. This is an example of one of the areas of rule that we expect to collect a lot of data about during that first year of surveys. It's difficult for us to assess how many complaints we'll get that speak to this particular rule and what kind of information we'll need to review while on site to substantiate an allegation of noncompliance, whether, for example, a CBA or a collective bargaining agreement will play part of that data collection, or whether payroll records. It's hard to know at this point whether we need to become more specific or whether this is specific enough. But that right now is the draft language. Yeah.
Which is here.
Hi.
Only representative. My question is, for large institutions, is it possible to have one member for every unit to be represented in the committee? So the way we approach it is that we do a cluster of a staff member representing, let's say, the acute care, critical care, perioperative, or paranesthesia. So that's the way we are done, and the hospital, in collaboration with the staff, has decided what the number is, the ratio. It's still unequal, but it defines, like, let's say, for example, me and my cohort covers the perioperative and paranesthesia, and together we cover 10 units, because it would be impossible to have 10 managers, because 10 staff members. So my question is, what's your thoughts about that? Because that's the approach that is feasible for us to have a committee that is functional. And then the other thing, what's your thoughts about including a non-RN into that committee, a CNA and LPN, that would potentially oversee a cluster or a bundle of units in that committee?
So we have a two-parter. The first part of this question, as I heard it, was are hospitals permitted to define nursing unit to include multiple subspecialties within a
cluster?
Yes, cluster. So language will be a little bit of a complexity here, but we could describe it as a cluster, or we could describe it as a unit with subparts. And the answer to that question is yes, under this current framework and also under the proposed rules. And the second question I heard...
The other one was the non-RN.
Yeah.
Since we, if we're to make this feasible, is we mandated to have a non-RN in that committee. But that non-RN might cover a cluster, and within that cluster might be 10 units covered by 50 to 100 nurses. what's your thoughts about that representation of all those nurses by a non-RN?
So this was a feasibility question that spoke essentially to potential pros and cons of putting a non-RN in a representative role of one of these clusters. We can speak to the rules and how the statute is designed, but won't take a position on whether that is a wise or a challenging position. And the rules at this point do allow that framework.
Can we define a little among ourselves in the committee, like, is there needs to be a consensus of the RNs in those units that non-RN would speak for them, or can that non-RN, I guess I'm looking for more clarity about how can that non-RN represent RNs and LPNs?
So this question that I heard was how are committee members selected, specifically how is the non-RN committee member selected? And you'll see that 3 of the 4 categories are set out in statute and of course can't be addressed, but there was an omission in statute that we've tried to bridge in rule. So what you'll see going through the draft rules is that we've identified how all 4 types of committee members are represented, and by 4 types I'm talking about represented and non-represented, RN and non-RN. And that's the proposed framework for identifying those committee members. And again, 3 of the 4 are set forth in statute and can't be changed, but that last one was designed to cover a gap in the statutory framework. That's a great question. Any other questions from the group? Yes.
I'd like to follow up on clarification. If I'm understanding correctly, this gentleman's question was, can an LPN or a CNA be the representative in the hospital staffing committee in lieu of a direct care RN? And your response was yes?
That wasn't the question as I
Okay.
understood it. The question as I understood it was that one non-RN committee member, how is he or she identified? And is he or she allowed to represent, in this particular provider's case, what he would describe as a cluster, but what we would see under this framework as a nursing unit?
But to clarify, it does have to be in addition to an RN having a spot representing that unit or group of units as well, correct?
So I think you're asking whether the representation is equal number of nurse managers, equal number of nurse. No, so I'm misunderstanding.
She's asking if that particular unit, has 2 representatives, 2 direct care nurse representatives, one RN and one non-RN, and that's not actually foreseen, or even that you would have one cluster or one unit. So let's just say it's a medium-sized hospital and you have, one surgery, or maybe you have a cardiac surgery unit. If you have 2 representatives from that unit, and I think in here it has 1 per.
Yeah.
So for that matter, no, it's not required to have an extra RN.
So under 441154, big C, it says include at least 1 direct care registered nurse from each hospital nurse specialty or unit. So my understanding would be that each unit or group of units as defined by the committee gets a direct care RN, and then an LPN or CNA be in addition to that, and of course there'd be another manager to balance that out.
Okay, so point me to the number again. That was
441154,
that's the easy part, yeah.
section 1, big C, and this is on page 3.
So for those of you looking through rules, and those of you looking online, what has been circulated to the group today is a collection of the current statutes, and also what Dana and I are looking at is a crosswalk between the current statutes and then the draft rules. So what you'll see when you crosswalk between the statutes and the draft rules are that we've tried to address some of the ambiguities in statute or some of the organizational challenges in statute through a rule. So the statute referenced just now, 441154, reappears in the rule 333-510-0105. And what you'll see is that we're talking about the composition of the committees and the language in statute and also in rule that addresses how many need to be nurse managers, how many need to be direct care staff, and then that one of direct care staff needs to be a non-RN or can't be a non-RN. And this seems like a rather nuanced question that might best be addressed when we finalize the rules and talk with specificity about each rule. But I'm seeing some expressions that maybe suggest the person asking the question disagrees.
Well, it seems like the law might contradict itself in that it's saying every unit is supposed to have an RN, a direct care RN from the unit, and then it says this other person other than an RN
Yeah.
is direct care. Well, if we take, we have a cardiovascular unit, we have an RN representation on the committee, but then we take a CNA from that same unit, is that considered double coverage from that unit? Where I think the RNs would say no. I think there's other people that would say yes, and I think that's where the clarification needs to come, is maybe how that non-direct care RN is chosen. I think does that, and if they, I guess I'm curious if I have a unit and I think that a CNA is going to represent in lieu of an RN for that unit.
I agree. I think what you're pointing is some of the drafting challenges in this particular statute. What we tried to do to reconcile it is focused on that section of 154, so 441154, section 1, little a, and then big B that addresses for the portion of the committee composed of direct care staff consist entirely of direct care registered nurses except for one position, which takes us out of that double representation challenge and puts us back to equal representation. So if you're talking about a committee of 12, you've got 6 managers, you've got 5 direct care, and then 1 that's not. Never easy, is it? Does that answer your question?
Can you repeat
Jen?
where in the rules, where in the rules this is addressed?
So
The
I
nurse
think
staffing
you're talking
committee.
about the nurse staffing committee requirement rule. So that's 333-510-0105.
Did you say that again?
Sure.
0105.
0105, so 105, that's rule number.
And I think it's not just how the direct care staff member that's not an RN is selected, but it's about their representation. And to be honest with you, sitting here, I'm not actually going to commit to coming down on it, because I think it is, there is some indication that it has to be 1 per, so there is some contradiction. And you know what? The more you read a statute, the more you find out, I wonder how that got in there. So I will say that we'll take a look at it and we'd be happy to respond in writing, but I'm not prepared to come down on that right now, because I think we need to do a little flipping and we need to compare the statute and the rules, because with torturous Cirque du Soleil contortions, did we figure out that one piece was missing and how they were selected and how the non-union, non-nurse member was selected. So we filled that in, and I am just not that astute that I would give you an absolute 100% right answer right now. So I'd have to defer that.
As we, David here.
David
As we put our
again.
committees together, that's kind of really one of the questions that I have with my co-chair as one of the co-chairs.
Mm-hmm.
That non-RN representation in the committee covering several units. So if there was some guidelines that would come to help us, maybe with an FAQ, I think that would be helpful.
Very good. And you do have our email addresses. We're very,
Thank you.
very available, so we'll get that sorted out. And this is the beginning. It's not the middle and it's not the end. So I just want to remind everyone, we will give you plenty of grace when we're out enforcing this and trying to understand how you're understanding it and trying to comply with it as direct care staff, as techs, as nurse managers. But we're also going to give ourselves and our surveyors grace to think that this is, there's a lot of new things here. There's a lot of things that come up every time you go out and you go, wow, I don't know how I would apply that. So we'll be learning, and that's the beauty of the Nurse Staffing Advisory Board, is that we can bring back all that information and kind of, put it all together and pose some questions to them, and they can ask us questions too, because they're hearing things in the field. So it goes in both directions. So we look forward to that. But we'll try and figure this one out sooner than later. So yeah.
I think the urgency around it is to put our committees to be able to do the work. And
Mhm.
if we can't figure out how to put our committees to work together, and then we're going to have trouble getting the work. And there's, I think everyone's feeling some pressure about getting the work done.
And there was an expressed sense of urgency from the Kaiser faction here on the left. Yes, which we agree with and we understand. Yes, in the front row.
Yeah, front row, that's what I said, Avery. So the hospital defined, I'm thinking about outpatient clinics and so on. Those are also covered with the hospital, who's covered in the same hospital, because I heard you say earlier, ambulatory surgery centers are not part of this requirement, or did I miss?
Oh,
So
independently
who's
licensed and
covered
certified ambulatory surgery centers. Yes, anything that's under the hospital license is covered by this.
And then outpatient clinics somewhere, like a
We-
HSU has a clinic somewhere in
Right.
Step 2s or something like that, that would still be under that hospital license.
Yes, it is. And we also had some acrobatic conversations about that, and tried to define sort of what type of nursing needs to be done. And I would hand it to you if you want to say anything to that, because I know you and Anna did have some post-rule conversations. And maybe when the rules come out, that we'll have a little bit more on that. I know that's going to be a big question. So, and the question was about satellite or off-campus provider-based, also known as provider-based locations. Clinics, they might be swimming pools, that are rehab centers that are up. They might be lab draws. There's all kinds of things that are included under that satellite definition, and that hospitals have, free reign to be able to define what types of services they're going to be offering there. So can I just let Annabelle answer that, and then we'll take the question from the back row.
So the shortest answer I can come up with is that if a service is offered under the hospital license, the hospital need to account for it and answer the question of whether nursing services are provided at that location or in that unit. And then of course that will drive your charter and your assessment of how to cluster, in your case, nursing units.
So, Jen again. Oh, she changed her mind. Oh, but there is a new person asking a question.
Jocelyn.
She from Kaiser?
Kaiser as well.
Yes.
So regarding that, if there is a clinic that is inside the facility, inside the hospital, but it's actually deemed an outpatient clinic, would that be included as far as you incorporate their needs into the staffing plan?
So some clinics, in air quotes, because that means a lot of things, that are located on campus and inside are not necessarily covered under a hospital license, yeah? And that is a health system and a hospital decision. And when we talked about preparation for the survey, our surveyors look carefully at what is covered and what is not covered, so that they don't cover things that are not covered, but look like they should be covered because they're co-located. more or less on the campus, or they don't cover things that should be covered, that are off campus, and they look off campus, and they may or may not be under the hospital license. So we will be looking at those lists. There are, I think last count, somewhere around 177 satellites for 60 some odd hospitals. So, each of the hospitals have, one or more off-campus locations where services are being provided. And over, they fall under that hospital certification, so they fall under the license and the certification of that hospital. So, I guess the answer is it depends. And if you ever have a question, you can check on those 177 satellites if this is a satellite or not. It's a licensing challenge that our licensing team looks at every single year, and they shake their heads because the hospitals change their minds and they want to redo things. And so we smile and we just record that and make sure that it's all official, and then we have a new number every year in January.
Well, we're after 6. Are there any more last-minute questions before we wrap up?
Okay, we will sign off and see you in August.
Thanks again to everyone for attending.